So we had the opportunity this year to present on cervical radiculopathy for the Interdisciplinary Spine Committee, or section. And what makes us perhaps somewhat unique in NASS is the cross-conversation across disciplines. And I think we're all happy to have the opportunity to share across disciplines and share knowledge. So why don't we take an opportunity to introduce ourselves and go around the horn here, and then get into some conversation. Okay. I'll kick off. I'm Evan Johnson, assistant professor of regenerative medicine and rehabilitation at Columbia University in orthopedic and neurological surgery. Dr. Suer?
I'm Michael Suer. I'm an interventional pain provider at the University of Wisconsin.
Dr. Barber?
I'm Lauren Barber. I'm a spine surgeon at Virginia Commonwealth University in Richmond, Virginia.
Rick Placide, also a spine surgeon in Richmond, Virginia at MCV, and professor of orthopedics.
Perhaps we can start with the diagnosis of the individual. So Dr. Placide, you presented on the history, physical exam, and differential diagnosis along with spinal masqueraders, right? Which is a topic you're somewhat known for. Can you speak a little bit in terms of the importance and the history and physical exam from your perspective, and maybe how that's been informed throughout your career, where technology has changed over the years, I imagine?
Yeah, so that's a great question. I still do believe in the importance of a history and physical exam when you first evaluate a patient, listen to their story, and have a thorough physical exam. It's not a complete physical exam. There are basics that we include in the exam, and then based on those findings, it may take us to another set of exam maneuvers, and you just keep going in that direction. I think it's critical because you brought up the differential diagnosis and masqueraders. And the physical exam itself can help you differentiate between an actual spine problem, which is what they would be coming to our clinic for, versus something that's not spine related, and that's what we call a spinal masquerader. And I think what I've learned over time is how important the history and physical is. Certainly didn't think that way when I first started practice, but over time and seeing a lot of bizarre things, I really think that it's almost an emphasis of mine now in the clinic when I see patients.
Dr. Barber, from your perspective, your fellowship and your residency is a lot more recent than Dr. Placide's. When a patient comes to you, I assume they've been told they may need surgery, they're coming for a surgical consult. What are things you find in the physical exam and history that point you towards surgery, or maybe point you towards referring a patient to someone like Dr. Suer, an interventional physiatrist or physical therapist?
Yeah, I agree with Dr. Placide. I think talking to the patient and kind of figuring out what their true complaints are. If the patient isn't able to answer those things, kind of getting information from the family as well is really important. Seeing what they've done already and what's worked for them and what hasn't worked for them yet is really important. I think it's really important to have a multidisciplinary approach and kind of work with other departments and services as well to kind of do what's best for the patient. But I think listening to the patient and the physical exam are extremely important.
And what sets off that alarm that says to you, this is a patient who I have to consider for surgery very quickly, rapidly, before there's more degeneration or some other factor, as opposed to this is a patient who needs to get more non-surgical care before we discuss surgery?
Yeah, so in our talk, we talked a little bit about red flags, but progressive neurologic deficit is something that we would definitely want to think about intervening more quickly on. Someone that has any concerns for myelopathy, but just focusing on radiculopathy, any weakness that matches with their other symptoms and particularly matches with their imaging studies, we want to think about intervening on.
Thank you. Dr. Suer, from your perspective, patient comes to you, maybe they have some weakness. They have some tricep weakness or some wrist extension weakness. It's consistent with a C6 or C7 radiculopathy. What are the things that tell you, I'm going to take my time, I'm going to work through these more conservative treatment options before sending the patient to a surgeon?
Yeah, I think a lot of that comes down to the history, which we talked about quite a bit during the talk. One point of emphasis that I think is important on the history is the progression of symptoms. And Evan, you can talk to this as kind of the physical therapist expert on biomechanics and movement, but really nothing happens in isolation in the spine. It's rare to have a 25-year-old with a single level disc herniation, that be the only thing going on. The majority of patients in our clinics are going to have facet arthropathy, myofascial pain, cervical radic, and likely on an MRI, multiple levels that are narrowed. And so identifying the underlying functional deficit that they have as it relates to pain or nerve function is imperative for me when I'm trying to understand what the next step is for the patient. And understanding if it's more neck pain, arm pain, is the pain causing weakness simply because it hurts too much to move it? And if that's the case, is it the neck? Is it the shoulder or an elbow issue that's causing pain, which then causes what looks like weakness? Or is this a true neurologic dysfunction that we're trying to do? So a lot of it, yes, we rely on the physical exam, but a lot of it comes down to history. And even talking through the history during the physical exam helps me understand where exactly the deficit is coming from.
One thing that comes to mind, and this was part of our presentations, was this idea of the tincture of time, right? So time is a healer, just as if we have a scar tissue. On the other hand, if you pick at the scab, it never gets to fully heal. So what I would ask, one thing I've seen, I've had the privilege of working with some extraordinary surgeons, and some of the more senior surgeons had this amazing ability to me to pause when other people wanted to act. They didn't hesitate. They would often act very aggressively without hesitation, but they would find moments to pause, and sometimes the patient's condition would express itself in such a way that it changed the whole treatment plan. Dr. Placide, can you speak to that?
So absolutely, and I agree with you. The way I like to think about it is if a patient has what I think is a relatively minor problem, now it's not to the patient, they have symptoms. But in my mind, if it's a relatively benign pathology, I'm very conservative, very conservative. If they have what I consider a very serious pathology, I'm very aggressive. There's not a lot of in between. You know, somebody that has a brand new diagnosis of metastatic tumor and cord compression, I'm going to be very aggressive about that. Whether it's calling up the phone and talking to colleagues, radiation oncology, oncologists, or operating on them. Somebody has a herniated disc and they have a bad radiculopathy, even with weakness. If this is a relatively new problem and the progression isn't significant, I'm very conservative with that.
And Dr. Barber, as you work with this patient group, how have you learned to distinguish the cervical radicular patient from the patient with other potential systemic conditions, whether it's neurologic or it's some other systemic medical condition?
Yeah, so I think something that I found very important is talking to the patient, getting that history on them, as well as the physical exam, of course, and you can kind of differentiate some of those things on your physical exam between deep tendon reflexes, the motor exam, sensory exam, and some of the other provocative maneuvers. But really, I found the most useful thing is kind of just comprehensively reviewing the system of the patient and getting their full history, even though we're just talking about their spine issues and they're just coming to a spine clinic, really thinking comprehensively about all the things that could be going on with them.
If you don't mind, let me flip it for a moment. And when have you found that you have to be very aggressive, even though your instinct was maybe to take your time and to let things play out, but you were in a situation where you realized or you perceived that being aggressive was the most significant thing to do for the patient at that moment, or necessary maybe?
Yeah, so for cervical radiculopathy, particularly in patients who have a progressive exam change or progressive weakness, I see them first and they aren't weak at all, they're doing okay, they just have pain, we send them for injections, they do okay for some time, and then they come back and see and follow up and you notice they're weaker on exam, or they subjectively say they're fatiguing and becoming weaker on exam. I would definitely think about being a little bit more aggressive as opposed to letting things declare themselves even more.
Dr. Suer, I sometimes see patients who come in and their primary complaint is pain without a neurologic deficit. They have maybe some paresthesias, right? But no true strength deficit or other progressive condition. But as I'm treating them, it becomes clear of other things that are going on. All of a sudden, you question whether loss of balance that they're expressing is it a idiopathic neurologic issue? Is it related to their diabetes? Or maybe there's something going on further with their spine or nervous system that hasn't been seen before. How do you handle that? And then out of curiosity, how do you interact with the physical therapists you work with as a rehab professional? Mm-hmm. How do you interact with them so that there's that conversation back and forth that can happen?
I think it goes back to trying to find that underlying cause of the issue, especially with balance. You do want to do a thorough neurologic exam, watch the patient walk, see if you can pick up any deficit as they're walking, whether you're seeing spasticity or a steppage gait, maybe some foot drop or something like that. So actually watching the patient walk and watching them walk different speeds. Some patients will do very well walking at a slow 1 to 2 comfortable miles an hour at a very comfortable pace. Speed them up to 3 to 4, and all of a sudden some of these deficits start to show themselves. And so when you have that, you want to start picking apart what you think the possible diagnoses are. This is oftentimes a really good use of an EMG to see if there is peripheral neuropathy or a myopathy that could be there that's causing some of these deficits. In some instances, we'll look at labs, whether that's inflammatory labs or other labs, just to look overall at health, whether there's an electrolyte issue or other systemic issue going on. But ruling out some of those things, I think, is really important. And then having a conversation when you send that initial consult into physical therapy, not just sending the note, but sending a message to say, hey, this is someone I saw in clinic, this is what I'm seeing. I don't think it's this because of X, Y, and Z have been ruled out. Here's where my thoughts are on what we should do for this patient. Please let me know how it's going over the next few weeks. And just starting the dialogue. I feel like if you wait for them to see a physical therapist and then wait for the message to come back, you may be getting behind. But if you start that ball rolling, you're going to get more messages back, and it's going to be a little bit better collaborative care with the therapists if you start managing this even before the physical therapist sees the patient with that preemptive message.
Interesting. I think I'd like to turn to something kind of very specifically surgical for a moment, but it befuddles me some in terms of the thinking of the surgeon. And that is the patient who comes in with a cervical radiculopathy, right? But you look at their imaging and they're kyphosed in the cervical spine. They have 2, 3, 4 levels of listhesis throughout the cervical spine, maybe grade 1, maybe moving towards a grade 2. They're not significantly unstable in a way that necessarily threatens the spinal cord, but they have a true cervical radiculopathy. You need to decompress them because they have a progressive weakness. How do you make the decision as to a simple decompression? You spoke of it some, Dr. Barber, the forearm anatomy versus the other procedure. And in that circumstance, where the larger surgery may disable the patient for a longer period of time or challenge them medically, if they're not entirely medically stable, but the smaller surgery is in some ways doomed to be insufficient or likely to be insufficient. How do you flesh that out and go through that process, the thinking behind the surgeon? Mm-hmm. Maybe you want to start, Dr. Placide?
Sure. So a kyphotic spine with deficits, a progressive, and multi-level spondylolisthesis, in my hands, that would be multi-level anterior cervical decompression fusion. But try to stay away from an isolated posterior approach with the kyphosis that's likely to progress, like you said. And that patient, based on your description, they're not a candidate for an artificial disc replacement, in my opinion.
And would you be specifically or particularly sensitive to restoring lordosis? And then how does that interact with their lumbar spine? Once you restore that lordosis, how does that interact with a larger sagittal balance in the system?
Mm-hmm. That's certainly part of doing the ventral or anterior approach, is to restore the alignment, because that is as important, if not more important, than the fusion itself at adjacent segment breakdown. If you fuse somebody in a flatter kyphotic spine from a ventral approach, you increase the forces on the adjacent segments much more than if the fusion was in a normal lordotic posture. So I think it's critical for balance of that part of the spine, and it should follow. I think it depends on the rest of the alignment of the spine, thoracic and lumbar. You know, how it might affect the lumbar. Yeah.
So and I know we're going far away from cervical radiculopathy, right? Mm-hmm. We're now in that area of deformity as well. But we do see these patients who present with a single level radiculopathy, but the challenge is there. From your perspective, Dr. Barber, how do you manage that? And kind of what's the criteria of I'll go this far, but not that far? Is it the potential for, distal kyphosis, junctional kyphosis? Or is it, hey, I need to get in and get out because the longer I have the muscles retracted and the more work I do, the greater the consequences? How do you balance those forces?
Yeah, I think that a big part of that goes with not only the multidisciplinary approach with other teams, but also talking to the patient and their family and looking at their goals. If you have a very kyphotic patient, chin on chest deformity that you're thinking about correcting, anteriorly, posteriorly, both, something else you need to think about is how will their feeding be? How will their dysphagia be? Will they be able to supplement their intake and nutrition postoperatively, or will they need some type of feeding tube to assist with that? So these are big surgeries and they're big discussions, and you want to do enough to approach the patient and their family and their symptoms, but also not do too much where you put them at more harm than good.
I think it's wonderful, and I knew you, Dr. Suer, that the two surgeons on board have been so sensitive to the biopsychosocial aspects, right? As the rehab professionals, we often feel or we sometimes feel that's overlooked and falls into our laps. But let me throw that in your direction. It could be that you have a long-lasting relationship with this patient. You've been treating them and helping to manage them successfully, but now the conditions progress to a point, and there's a certain trust that they place in you as they go through this decision-making process. Can you talk about just how you approach the conversation that it's time for surgery now, and kind of how it's informed by just your experience? And maybe I'll take it one step further. What would you say now that you didn't know to say, or what would you do now that you might not have known to do early in your career?
So I think a lot of that goes back to the initial first time I see a patient. First time I see somebody, I almost always go through 4 different broad treatment options, whether that's physical therapy and chiropractor, medications, injections, and surgery. And so the first time I see somebody, I kind of lay out all of these options and say, here's where I think we are. These are the things you would want to consider if we are ever going to go after these other things. And that's even within the medication realm. We may talk about, Tylenol and ibuprofen, NSAIDs being better for arthritis, but if you start to develop radicular pain, we may look more at the gabapentin, Lyrica, Cymbalta type meds. As time progresses, you develop this relationship with the patients, a lot of different ways. You start to know, honestly, their family and their kids, and it's not uncommon for me to get done seeing a patient and they say, "Oh, how are your kids doing? How's soccer going?" And so you really get to know them and you develop that trust. And if you're able to establish that early, the first time you look at them and say, I think you need to see a surgeon, most of the time they say, "Okay, you've been steering me right this whole time. We've gotten to know each other." Other times, that conversation doesn't go well because they want to stay with you. And you have to say, "Look, here's what I'm seeing on exam. I'm seeing strength deficits. We're doing the conservative things. It's not getting better. I don't know if doing the same thing over and over again is going to yield a different result. I think we need to do something different." And ultimately, I'll often tell patients, simply meeting with a surgeon does not obligate you to get surgery. It allows you to understand what the options are. And at that point, if you decide surgery is not for me, the risks are too great, well then please come back and I'll help you out where I can. But I think it goes back to that initial visit when you're talking to patients to try to understand what they want out of their healthcare, but I would say more important, what in their life is impacted by the pain. So they want something out of the healthcare, but that's usually for some event, whether that's work, visiting with friends, being able to do stuff around the house, that they need improvements there, and that's what you're trying to help them with. So understanding where they're limited from a functional day-to-day basis.
So let me put everybody on the spot. In one sentence, I'd like you to say, what do you know now about your patient around cervical radiculopathy, perhaps, that you didn't know then? Dr. Placide?
I've learned to trust the patient's history and my physical exam much more tightly.
Okay. I've learned that spinal masqueraders are not zebras. Sometimes they're horses, and they're more frequently happening than we think.
Dr. Suer?
I think it's setting expectations with patients, and so that they understand what the goals of treatment are, so that your goal of a treatment aligns with what their expectation is of that treatment.
And for me, it's, if I have to give up all my tools, the one tool the patient most needs from me is patient education delivered empathically. Thank you all. That was fun.
Thank you.
Thank you.
Thank you.